Moving on to the next session, with great pleasure, I would like to invite Dr. Nishchita R. Ma'am, Consultant Geriatric Physician and Diabetologist at Spurs Hospital, Bangalore. Privileged to have you, ma'am.
Good afternoon. It's an honor to be here, and it's my privilege to introduce the next speaker, Professor Dr. Bhavatharini, Senior Consultant Diabetologist, SRC Diabetes Care Center. Madam is the President of DIPSI, that is the Diabetes in Pregnancy Study Group of India. She's the Secretary of Tamil Nadu RSSDI. She's been awarded the Best Teacher Award. She is the founder member of Tamil Nadu Chapter API, DIPSI, RSSDI, and DFSI. Madam, I welcome you, and we are curious to listen to the next session of Peripartum Management of Diabetes. Over to you,
Thank you, Chairperson. My dear colleagues, very good morning, and pranams to my mentor, Professor Dr. Seshia. I immensely thank Dr. Srinivasamurthy for this wonderful opportunity. Coming to the peripartum management of diabetes, first and foremost, is it necessary to treat diabetes in pregnancy? Why do we treat? Of course, we need to save 2 generations at the risk of developing diabetes in future. That is the mother herself and the offspring. And what is this peripartum period? It is the period 20th to 22 weeks of gestation up till 4 to 6 weeks after delivery. It represents a period of significant structural, functional and hormonal changes, including increased risk for cardiovascular, physical and mental health challenges. And my mentor has done a study long back in 2007 irrespective of the trimester. He did a screening and has found the GDM represents in all trimesters. It's present in all trimesters. That is about 16% in the first and 22% in the second. And of course, it's very much high in the third, that is 61%. But remember, if you are not going to screen in the first half, you are going to miss almost 40% of the cases. And he has repeated the same after 10 years in 2006, and he has found it has been doubled in the first trimester from 16 to 32, and also the second from 22 to 32, and the third, of course, it has come down. This is mainly because of our improper lifestyle. And the same thing in 1980, Banting lecture, what they said, insulin dependent diabetes type 1 is the only diabetes passing through pregnancy. But the same thing in 2020 Norbert Finkel lecture, David Simmons, he has told it is not type 1 alone, along with the type 2 diabetes and prevalent diabetes, that is the diabetes detected for the first time during pregnancy because of the hormonal influence, is also very common, along with what we say GDM, which occurs because of the hormonal influence. Why I am saying all this? Because we need to classify properly before we go for the treatment part of the management part. So we do have pre-GDM, that is pre-existing diabetes, that is the type 1 and type 2 passing through pregnancy, and also we have the diabetes detected for the first time during pregnancy. Then of course we have gestational GDM. The one pre-existing diabetes is present right from the day of first, that is the day of conception. And why we do need to classify like this? Because all hyperglycemia in pregnancy is not the same. The visits differ according to the blood sugar, the glycemic goals differ. There is different fasting and postprandial, and we do have a different SpA1C cutoff, different meal plan, different HP percent, different BP and pulse, and also different treatment regimes. Coming to the management, of course, the patient would have been following already the non-pharmacological managements like diet and exercise. That is the mainly in pregnancy, the plate model, half the plate full of vegetables and greens and quarter carb. That is, we need to reduce the carb and increase the protein. It should be equivalent to all the amount of carb what we take, and also regular exercise daily not enough. We need to do 5 to 10 minutes of exercise after every meal. And coming to the pharmacological agents, of course, we are all very familiar with the metformin and glibenclamide. Of course, metformin is approved. Glibenclamide, as far as India is concerned, we do not use it. And the mainstay in the treatment of hyperglycemia in pregnancy is insulin. And this is the plate model where half the plate full of vegetables and greens and quarter carbohydrates equal to that of proteins we need to consume. And fasting and feasting both has to be avoided during pregnancy. And this, instead of taking 3 big meals, it has to be split into equal parts, taking once in 3 hours. It should be split meals. So that the blood sugar is not rising. And of course, metformin has been approved very clearly by UK. That is, the metformin is the only oral anti-diabetic drug which can be used from conception to delivery. Not only this, we do know that preeclampsia is also a feature of insulin resistance. Taking metformin also reduces preeclampsia. And our own endocrinologist from Delhi, Sabdaji Bhattacharya, he has followed the children who have been put on metformin for up to 11 years, and he has seen that it's the same. Those who took insulin and metformin, the result was the same. They didn't have any extra effects. And we need to know what are the insulins that can be used during pregnancy. All human insulins, whether it is regular, that is short acting, or intermediate NPH, or the mixtures 30-70 or 50-50, anything can be used. Coming to the analogs, the rapid acting analogs, aspart and lispro can be used, but not glulicin. And in ultra fast acting, Piast can be used. And long acting glargine, if the patient is already on glargine, it can be continued, otherwise do not start with glargine. The detamir and deglutec are approved, and the pre-mixed, of course, the Novomix 30-70, Humalog mix 50-50, all these can be used. And what are the regimes you have in pregnancy? Of course, we have basal, split mix, pre-mix, either 50-50 or 30-70, anything can be used. Of course, in pre-GDM, we need to go for basal bolus in type 1 and type 2, and also the prevalent GDM. And remember, in the first trimester, the requirement of insulin comes down compared to the previous state. And in the second, it raises to 0.8 units per kg per day. And the third, it still raises because of the increased hormonal influence and the growing fetus, that is 0.9 units per day. At term, of course, it becomes 1 unit per kg per day. In GDM, the requirement is variable depending on the time of onset and of diabetes, and also the severity of hyperglycemia. In total daily dose, whatever you take, it has to be split into 2/3 in the morning and 1/3 in the night. And in this also combination, 1/3 is short acting and 2/3 is intermediate acting insulin. For example, if you are giving 18 in the morning, 6 is short acting and 12 is long acting. Again, in the evening, if you are giving 12, that is 1/3 you are giving in the evening. Out of this, 4 is short acting and 8 is long acting. In this way, just rough calculation I am giving. Usually in women with GDM, they do not require more than 20 units of insulin for their glycemic control, whereas in pre-GDM, that is type 1 and type 2 passing through pregnancy and also the prevalent GDM, they will require very high doses, and they usually require multiple doses, and you have to go for basal bolus regime. It is also always individualized and has to be adjusted according to the blood sugar and follow-up. So we have the regular plus intermediate in the morning, or regular plus intermediate in the night, or we can give 2 regular for the morning and afternoon meals and 1 mix in the night, or all 3 meals we have to give regular and long acting in the night. How to test? If at all you are giving intermediate acting in the morning, you need to test in the night, and short acting before breakfast, pre-lunch has to be seen. Intermediate acting, if you are giving in the night, the morning blood sugar has to be tested, and short acting before dinner, you have to test the bedtime blood sugar. And what Audit Langer said, it is appropriate to use the dose needed to achieve normoglycemia rather than thinking about the use of too much insulin. Our main concern should be blood glucose rather than the dose of insulin. And of course, hypoglycemia is a problem, but what Drury said, he has said, hypoglycemia is common, happily it is not harmful, and I have records of 100 pregnancies in which hypoglycemic coma occurred at least once without any harmful effect both to the mother as well as the baby. But always, whenever you put the patient on insulin, whether it is pregnant or non-pregnant, you need to teach first hypoglycemia prevention by doing frequent home blood sugar monitoring and educating regarding the symptoms of hypoglycemia and what are the remedies, use of analogs to achieve better postprandial control, which has a lower risk of hypoglycemia. And of course, if possible, they can go for CGMS or just SMBG is enough to rule out this hypoglycemia. And regarding the site of injection, of course, first trimester it is the same like non-pregnant, whereas in the second, use the lateral aspect of your abdomen staying away from the skin overlying the fetus. If the third also, you can use the lateral aspect, or if the patient is very anxious, you can go for the lateral aspect of the thigh or gluteal region or the arm. Only thing is, it has to be rotated. Rotation is very important. And what are the target according to DIPSI guidelines? The mean blood sugar should be 105, fasting less than 90 and 2 hour postprandial, all meal, not cross 120. Mean should not go less than 96 because it may cause small for gestational ages. Always remember like how we measure the BP in the night, and we need to see the blood sugar also in the midnight, and it should not go below 60. Of course, you would have seen in all the time in range that for the pregnancy, GDM or hyperglycemia and pregnancy, they have a range from 54 to. So remember, it should not go below 60. And this abnormal postprandial glucose measurements are mainly the cause for adverse pregnancy outcomes. And regarding the visit up till 28th week, you can ask them to come in once in 2 weeks, 15 days. After 32 weeks, of course, once a week. But in high-risk cases, that is the pre-GDM, what all I said, they have to go for either SMBG or if possible AGMS is advocated. And it all depends on the severity of the blood sugar. You may do 2 days once, 3 days once, weekly once, or in a day 2 to 3 times or 7 times, 10 times. All depends on the severity and how she responds to the treatment. And of course, every visit you have to see the blood pressure and fundus and the kidney has to be monitored because they get worsened during pregnancy. Always you should keep in mind this in pre-GDM. And ultrasound in the first visit, that is at 18 to 20 weeks you do once, and from 26th week onwards you have to do every 2 weeks once. Regarding the AGMS and the blood sugar control in pregnancy, it is 24/7 round the clock control. Please do not see either in the morning or night alone. Ask them to come. If you are checking the blood sugar in pregnant patients, ask them to come in turn. One time they can come in the morning, the other time in the afternoon, and then in the night. Keep rotating the visits if it is not possible to do SMPG, or you can ask them to do the whole day once in 15 days a week and bring them, and you can alter your treatment. So always follow the blood sugar before and after all 3 meals, with one at bedtime if possible, and maintain the time in range for GDM more tighter. It is not like non-pregnant, the values differ, and also at least more than 70% in case of type 1, whereas in GDM and type 2, it has to be for more than 90% of the day, they have to be within the range. That's very important. And of course, this is very useful in gestation type 1 diabetics or brittle cases passing through pregnancy. And this closed loop again is also useful. This consists of insulin pump, continuous glucose monitoring, and a control algorithm. This can also be used. And remember, we always use steroids in all these cases. That time definitely there is a very high fluctuation of this blood sugar. Please do not leave. And on the first day you split the doses into 4. Usually they will be on basal bolus. first give the dose, the first dose, and on that day, night alone has to be increased by 25%, and on the second day, you give the second dose and increase all doses by 40%, and third day, you continue the increment of 40%, because definitely we have seen practically the blood sugar shooting like anything, and on the fourth day, you can reduce it to 20%, fifth day, just 10% increment, and later, depending on the blood sugar, you can revert to normal. And timing of delivery, GDM who are control on diet and exercise, you can extend up to 39-40 weeks unless otherwise it is indicated. And GDM well controlled by medications, again you can go up till 39 or 40 weeks. Poorly controlled, you need an expert opinion, and earlier delivery is may be required, and it's a trade-off between the risk of prematurity and stillbirth. And usually it's between 37 and 38 weeks it's justified, and late preterm period is of course 34 to 36 weeks is reserved for the failed in hospital attempts of glycemic control or with abnormal antepartum lethal testing. And insulin, of course, when active labor begins, the infusion is used. Why we do go for the infusion? Because it is under our control. We can stop it, increase it, change it to dextrose. All these we can do. So always go for infusion. In contrast, GDM will not require any once the placenta starts detaching. No insulin may be required after the expulsion of the placenta in true GDM. In a known diabetic, insulin has to be adjusted according to the blood sugar. And intrapartum, you need to withhold the morning dose of insulin while planning induction or cesarean delivery early morning, and start on 5% dextrose infusion. They need adequate nutrition. It should be 100 ml per hour. And another drip containing insulin infusion, 0.5 units per hour, slowly infuse. Again, depending on the blood sugar, you have to adjust and maintain the blood sugar between 80 to 110. And during labor and delivery, the maternal hyperglycemia, because of the stress, she can have, being a hyperglycemic lady, she can go for more stress, and still the hyperglycemia increases. This will stimulate the fetal pancreas to secrete insulin. It goes for fetal hyperinsulinemia, which can worsen the acidosis. So maintain the blood sugar always between 80 and 120, and feed the patient the routine GDM diet and maintain the basal glucose requirements. Monitor the sugar 1 to 4 thali depending on the severity of her, and give insulin only if the sugars are more than 120. And of course, during Caesar, later stages of labor, start dextrose to maintain the nutritional requirements. Here it should be 150 to 200 ml, little more. And elective Caesar, check the blood sugar fasting. If on target, no insulin, start the dextrose strip. Continue hourly monitoring. Post delivery, keep the patient on DNS, dextrose containing, till fed. No insulin unless the sugars shoot up. And during postpartum for pre-GDM, you will see the blood sugar coming down. So you need to have the doses of insulin and continue to check the blood sugar immediate postpartum. For GDM patients on insulin therapy, that is, we have one control with meal alone, the other were put on insulin. You check the fasting and BP and then treat insulin if necessary. Whereas those on medical nutrition therapy, once the placenta comes, they will not have any influence. So the blood sugar totally reverts to normal. They may not require any treatment. But all these you need to see depending on the blood sugar. And very important thing is stress management. They do have at the later stages of pregnancy and also postpartum. So you also need to treat stress management. Puerperal psychosis, we are just ignoring. This is very common. And advocating lactation is very, very important, because this lactation has a lasting favorable effects on the maternal metabolism to protect against future disease risk. It reverses the pregnancy adaptations and also resets the maternal metabolism. And postpartum follow is very equally important like antepartum care. You have to follow her at 4 to 6 weeks and do the GTT with 75 grams, the same thing. And even if she is negative, you have to repeat after 6 months and after every year. but the values differ. In pregnancy, fasting is less than 90, whereas non-pregnant, it's enough if the fasting is less than 100, and post-glucose 140. And in our country, that is in Chennai and Delhi, they have compared this because it's very difficult to bring the ladies after delivery, they don't turn up. So what we have done at the time of discharge, we have done a GTT and compared that with 4 to 6 weeks, both are same. So remember, at the time of delivery, thank you. At the time of discharge, third day itself, you can do one GTT and confirm if she continues to be diabetic or not, then you can further follow up. Thank you. Thank you.
Thank you, ma'am. It's been a very comprehensive and detailed session about peripartum management. We can take 1 or 2 questions from the audience.
I have come across one case of GDM. It was 20 years back, diagnosed during pregnancy and followed up. And her kids are now 23, 24. The mother is still non-diabetic. Though her maternal side there is a family history, I think it is what suggestions do you want to give for the patient?
So here the case is any GDM, if you come across, she is a potential candidate to get diabetes in later life. So only I said that she need to be followed very regularly during the postpartum period. And if she accepts all what you say, the lifestyle modification and other measures, if she strictly follows, definitely she can either postpone or she may not get diabetes. It doesn't mean because her mother is diabetic, she should also become diabetes. This is what we call, we are trying remission, reversal, all that, no? If she is following a proper lifestyle, definitely she need not become diabetes at all.
Yeah, that is what we noticed. Last 24 years, she never manifested any clinical or laboratory findings of diabetes. And she is neither obese nor...
she is maintaining,
yeah,
she is following the
well.
strict.
Yeah, thank you.
And of course, now we are doing the primordial prevention. My mentor, Dr. Seshia, he has this doing prevention of GDM itself. That is what he is doing at the 8th week of pregnancy. Remember, it is 8th week of pregnancy, do one postprandial. It's not with glucose, just do one postprandial blood sugar. If it happens to be 110 to 119, we put them on meal plan plus metformin. Why we do this? 110 is the fetal renal threshold. Another thing, Hernandez has studied all the pregnant women's, the normal blood sugar for 40 years in 12 different countries and has found the 2-hour has to be less than 110. 99 plus or minus 10 is the normal. So it should not cross that to not to get any problems. And the other thing, the fetal pancreas starts functioning by 11th week of pregnancy. Once the blood sugar crosses 110, it will start secreting, which is irreversible. This hyperinsulinemia is the cause of all problems. As long as it is inside the mother, it takes glucose from the mother. Once it is born, it goes for recurrent hypo. Many of you may say the blood sugar of the mother is normal, why the baby is big, or goes for polyhydramnios, or why the baby goes for recurrent hypos. All these are because of undiagnosed GDM during pregnancy. If you are not diagnosing before 10 weeks, you are going to miss the diagnosis because of the fetal handling of the blood sugar. The fetus will go for hyperinsulinemia, and even if you diagnose later after 10 weeks, giving all the treatment will prevent preeclampsia, preterm, all that, but not the future occurrence of diabetes in the fetus. It will continue to have hyperinsulinemia, it will eat more, it will put on obesity, and in the future it will get early IGT and all other non-communicable diseases. So we catch the pregnant women at 8th week of pregnancy, put them on medical nutrition therapy plus metformin if the blood sugar is between 110 to 119, postprandial. Glargine, if the patient is already on glargine, you can very well continue. Otherwise, do not start with it. We have Levemir also, they have stopped. So, Deglutec is available.
Thank you, ma'am. I would like to thank the organizers for giving me this opportunity. I'll hand it over to the organizers. Thank you.
Thank you. Thank you all.
Let's give them a good round of applause. Thank you, respectful speaker and chairperson, for throwing light on the peripartum management of diabetes, highlighting the importance of the meticulous care during this critical period. I now request you to proceed to the selfie stand for a photograph.